Welcome, everyone. My name is Ruth Wilcock, and I'm the Executive Director of the Ontario Brain Injury Association. And thank you for joining our webinar today. OBIA has been educating people in the field of brain injury for close to 35 years, and we are very excited about this webinar series that we are doing in collaboration with Brain Changes Initiative. Just to let you know, the founder of Brain Changes is Dr. Matthew Galati, who sustained a very serious traumatic brain injury in 2013. However, he was able to return to medical school and now is a fully licensed physician. Today, our special speaker is Dr. Leddy, and I'm so pleased, Dr. Leddy, that you are going to be presenting today. However, we could not do these webinars without our sponsors, and I'd like to invite Mark Leno from Pons to come and introduce Dr. Leddy. Mark?
Thanks very much, Ruth. It's a pleasure to be here. It's quite a journey, and I have to say that it's been a real pleasure to start to work with the Brain Changes organization. We've had the pleasure of getting to know the Galati family, and me personally spending some time with Dr. Matthew Galati and hearing his story and seeing his passion and dedication to helping patients with brain injuries across the country, and their mission is certainly not lost on us. I'd also like to thank you at OBIA for taking the lead in helping to pull together these awesome speakers over the next several weeks. We're really excited to be kicking this off today. And finally, I'd like to thank one of our clinic partners, Matt Sanchez, and the team at NeuroChangers. Just a great group of people helping a lot of patients. So with that, let me please introduce the guest speaker today. Dr. John Leddy is Professor of Clinical Orthopedics and Rehabilitation Sciences at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences, a Fellow of the American College of Sports Medicine, the AMSSM, and the American College of Physicians, and Director of Outcomes Research for the Department of Orthopedics. He is a Division I team physician and medical director of the University of Buffalo Concussion Management Clinic. He is a member of the expert panel for the Berlin 5th International Consensus Conference on Concussion in Sport, and a consultant to the National Institutes of Health on sport concussion research. In conjunction with Dr. Barry Willer, he developed the Buffalo Concussion Treadmill test, which many of you will certainly know about. I've had the pleasure of listening to Dr. Leddy talk about this topic before, very recently with Charles Tater's conference, and I think you're all in for a real treat. It's a wonderful talk, and I turn it over to you, Dr. Leddy.
Thank you very much, Mark. Can you hear me, first of all? Can everybody hear me?
Yes, we can.
Okay, great. Yeah, thank you for that kind introduction, and I want to thank Brain Changes, Dr. Galati, his father, and OBIA for inviting me to give this talk today. It's something I'm passionate about, and I hope that it provides some useful information to the audience, and happy to take questions afterward. I can share my screen, I assume, right?
You should be able to, yes.
Okay. Can everybody see that?
Yes.
Okay, I'm going to put it in presentation mode. That works. There we go. Okay, so the group asked me to speak about exercise and improving brain health in general and for concussion specifically. So that will be the talk today. I do have some disclosures in terms of grant support and scientific advisory boards, but they do not affect the content of this talk, and no commercial support was received. Let's talk a little bit about exercise and brain health in general before we get to concussion. This was a recent review that I thought was very good, Cabral et al. In Neurotherapeutics a couple of years ago. And basically, they investigated the link between regular physical exercise and cognitive brain health. They talked about various mechanisms that include, and may include all of these, or some more than others: brain volume and connectivity between brain regions, cerebral perfusion of blood, synaptic plasticity, neurogenesis, or the growing of new connections, and regulation of trophic factors like BDNF, which is a brain-derived neurotrophic factor that is involved in neuron repair, and vascular endothelial growth factor, which is involved in making new blood vessels. And in older adults, like I'm getting, reducing cardiovascular disease risk, high blood pressure, diabetes, obesity. These may all help our brain health. And then they looked at exercise in terms of short duration, up to a few days, up to 4 weeks, medium, 6 months to longer, and long-term exercise, 50 weeks and beyond. In terms of their the ability to change these various factors and improve upon them. And this is a very busy slide that's from the article, and I'm not going to go through it in detail. I will summarize it, but you just see that as exercise goes from short to medium to long, you have different mechanisms being invoked in terms of connectivity, structural changes, trophic factors, etc. So it's a very nice study if you want to get it and look at why your brain may be getting better with exercise. Basically, in the short term, defined as 1 day to 16 weeks, they found evidence that there was improvements in cerebral blood flow. That's what CBF stands for, connectivity between brain regions on MRI studies, new blood vessel formation, and increased brain volume in the hippocampus where we form memories. That's aerobic exercise. There are even some benefits of resistance exercise with or without aerobic, increasing in things like BDNF and insulin growth factor 1. If you then look at more medium-term exercise programs lasting up to 40 weeks, many of the same things happen in terms of connectivity, things like BDNF. And also, we do see that there are improvements in terms of exercise intensity. So if you exercise at higher intensity, say at 80% of your VO2 max versus 65, you're likely to get more benefit. And the longer you do this, and 150 minutes per week seems to be sort of a key variable here, the more benefit you get. What about long-term exercise? So chronic, years and beyond. So all these types of different exercises, coordination exercises, aerobic resistance, seem to improve white matter integrity, hippocampal volume, neural efficiency, increases in IGF-1 with resistance training. So it looks like exercise by whatever modality you choose, aerobic, resistance, coordination, all of that is actually very good for your brain. And the longer you do it, probably the better. And what about in terms of maybe preventing dementia? Well, aging, genetic factors, medical factors, lifestyle, all contribute to the risk of Alzheimer's disease predominantly, and other dementias. And around a third of dementia cases are considered attributable to these modifiable risk factors like physical inactivity, smoking, and hypertension. And again, exercise is a key intervention for influencing all of these variables and therefore reducing the risk of age-related cognitive decline and dementia. Let's move on to concussion, since this is the focus of the talk. I'm going to talk about some of the physiology of concussion with respect to the autonomic nervous system. The autonomic nervous system is an important part of your brain that's housed basically in the oldest part of your brain, the brainstem, and it has many other connections, but this is a little graphic that shows that in the medulla, or in the part of the brainstem where the control centers are for your heart and your lungs, the autonomic nervous system receives information from various organs, the heart, the contracting muscles, the aortic and carotid arterial receptors in the aortic arch. And then it sends out signals to control your heart rate and blood pressure, your blood flow to your organs and brain, and your ventilation. So it's really the system that's keeping us alive, and it works at a subconscious level. A number of years ago, we sought to see whether the brainstem itself showed any evidence of injury or change after concussion. And this was a study in patients who had symptoms for more than 6 weeks after their concussion. And we did a diffusion tensor imaging study, which looks at the integrity of the white matter. And I'm not going to go into great detail, but when we looked at the brainstem in particular, we indeed found that there were changes in the white matter signal after concussion in the brainstem. Most of the MRI studies that you will see quoted in the concussion literature look mainly at the cerebral cortex. And so the brainstem was sort of a forgotten stepchild in a way. And we've become interested in that because of our idea about using exercise to treat concussion. And again, your heart rate and blood pressure and your ventilation are controlled largely through the autonomic nervous system, a main part of which is in the brainstem. Now, what about the function of that part of your brain? I think there's evidence that the structure of it can be affected by the injury that produces concussion. But now we want to look at the function of the autonomic nervous system, and there are two branches of it, the sympathetic and the parasympathetic. So the sympathetic is the flight and fight response, and this is a study of SNS, or sympathetic nervous system function, in college athletes within 1 week of sport-related concussion. And we compared them to age-matched healthy control subjects. And we imparted a noxious stimulus to try to engage their sympathetic nervous system. And I have this lame joke that in Buffalo in February, this is how we do it. We stick them in a snowbank and then we measure their response on their gloved hand. But no, this is really how we do it. We put them in a lab and we put their entire hand in very, very cold water. This is ice cold, 0 degrees Celsius water. And in the other hand, we measure their beat to beat heart rate and blood pressure. Now, in a normal person, this would elicit an increase in blood pressure and heart rate because it's pretty noxious. And in these graphs, the normal people are in the black circles and the concussed are in the red squares. And if we look at systolic blood pressure, diastolic blood pressure, peripheral vascular resistance, and cardiac output, which is the amount of blood your heart is pumping out every minute to your body and brain, you see that the concussed patients have a very flattened, non-significant response when compared with the healthy control patients. So this tells us that the sympathetic branch of the autonomic nervous system is not switching appropriately or engaging appropriately to an imposed environmental demand. Now, remember, this is not under conscious control. This is an unconscious reflex activity. So this is not involving any kind of motivation on the patient's part. Well, what about the other part of the autonomic nervous system, the parasympathetic? For this, we look at something called heart rate variability. This is the variation in the heartbeat that we all have. So no one's heartbeat is perfectly regular, it turns out. And if you examine this, this reflects the status of your autonomic nervous system. That is the balance between the parasympathetic and the sympathetic branch. If heart rate variability is high, that means the parasympathetic branch is predominant, and that's good. That's what athletes get through regular training. If it's very low, though, that means the sympathetic branch is predominant, and that's actually not very good. That's got negative prognostic value for people with heart disease or anxiety or diabetes or PTSD, for example. Now, this is another study where we are looking at the PNS function in the same types of athletes, college athletes within 1 week of concussion. We're looking at the parasympathetic function. And here we're going to measure, I'll show you two measures of heart rate variability. Now, in this study, we don't put their hand in the water, we put it right on their face. I know this looks like torture, especially in Buffalo in the winter. And it is in a way, it's not very comfortable. But what this does is stimulate the trigeminal nerve in the face. And interestingly enough, instead of getting a sympathetic response, you get a parasympathetic response. That is, the heart rate slows down. And if we look at, again, two measures of this parasympathetic response, the normal healthy subjects are in the black circles, the concussed are in the open circles. We see that the concussed, again, in two measures of this parasympathetic engagement are not engaging as healthy people should be. They have this very flat, non-significant response. So this shows that the other branch of the autonomic nervous system isn't even working properly early after concussion in college athletes. So it looks like there's a switching problem after mild TBI, at least in this population. And this cartoon just shows that the autonomic nervous system is ubiquitous. It is responsible for everything from constricting the pupil of your eye all the way down to emptying your bladder. And in between, you have control of your heart rate, blood pressure, breathing, and digestion. So there is a problem with autonomic nervous system function after concussion that we can measure. Now, why consider exercise to improve concussion physiology? On the left, I've listed what a concussion does and also what deconditioning an athlete does. So we used to tell athletes to stay out of exercise until their symptoms went away. And that, in effect, condemned some of them to staying sedentary for weeks and sometimes months. Well, if you do that, you will have adverse effects on autonomic nervous system control, on the control of cerebral blood flow, especially during exercise. There are downregulation effects on neuroplasticity, or the ability of the brain to repair itself after injury. There are psychological and sleep issues that both concussion and deconditioned athletes experience. Now, if you then have them exercise, you get improvement in autonomic balance. You get improvement in something called carbon dioxide sensitivity as well. That's a brainstem physiological function. I won't talk about that today, however. The regulation of cerebral blood flow improves with exercise, especially during activity, but also at rest. Exercise upregulates the genes that are responsible for neuron repair, like BDNF. It improves mood, it improves sleep. It has lots of potential benefits that would make it a candidate to help somebody recover from a concussion. Now, I talked about cerebral blood flow. This was a small but interesting study we did a number of years ago, where we took patients with concussion, and some were given an exercise program, aerobic exercise. Some were given a stretching program that did not affect heart rate, a placebo stretching program, and some we had healthy controls. And we had them do this math task over 5 minutes in an MRI unit, and we measured their cerebral blood flow by something called functional MRI. So they were tasked with this little math quiz, press a button if it's more or less than 5, and we had them do that repetitively over 5 to 10 minutes or so. And we then measured their blood flow and their symptoms. And this shows the symptoms, and only the subjects got the exercise, the aerobic exercise. Actually, they're the only ones there whose symptoms improved. The subjects that got the stretching improved a little bit, but not significantly. What happened to their blood flow? Well, those, now these were patients, I should say, who had persistent post-concussive symptoms. That's what PPCS means. So they had symptoms for more than a month, generally more than 6 to 8 weeks. And if we looked at the group that got stretching, who did not recover in terms of symptoms, this is their brain blood flow during that cognitive task. And what you see is a lot of red here, a lot of blood flow. So they're using a lot of resources, a lot of blood and glucose to solve the task. Now, they were able to do the task, but you can see they're using lots of their brain to do that. And this was no different in the stretching group from before the intervention till after. Those who got the aerobic exercise, however, had good performance on the task as well, but you can see here that their brains look a lot more efficient in terms of doing the task. That is, they're using far fewer resources to do the task after they've recovered with exercise when compared with the people who got stretching and who did not recover. So, small study, not a randomized trial, but showed that aerobic exercise at least appeared to change cerebral blood flow control in association with resolution of symptoms and good cognitive function. So a number of years ago, Dr. Willer, who's from Canada, by the way, he lives in Fort Erie but works in Buffalo, we wanted to have a way to assess exercise tolerance in athletes more systematically. Back in the 2000s and the early 2010s, there was this idea that you should somehow get people more acclimated to exercise slowly after concussion, build up their tolerance, but there was no real systematic way to assess that. So we looked into the cardiac literature, and thought about using a cardiac stress test, but to stress the brain for concussion patients. So we modified a cardiac treadmill test called the bulky protocol because it's very safe. And what we do is we put the patient, as you can see in the picture, on the treadmill and keep it at the same speed. We monitor their heart rate and their symptoms every minute. Each minute, the incline is increased by 1 degree until they have a symptom limitation. That is, they stop exercise because their concussion symptoms go up, not because they're fatigued or their legs are burning out. And we call that a symptom limited threshold. We take the heart rate at that point, and then, as I'll show you in a minute, we use that to prescribe exercise. We first did this in patients who were experiencing prolonged post-concussive symptoms because we had to make sure it was safe. We didn't think we could do this too soon after concussion because we know that exercise can increase concussion symptoms, and we didn't want to harm them or delay their recovery. Now, if the patient can exercise to maximum exertion and he or she stops because they're out of breath or their legs are burning, we think that means that at least cardiovascularly and probably cerebrovascularly, they are physiologically recovered. We think they've regained control of their cerebral blood flow. Doesn't mean they go back to play right away, but they can do aerobic training. And more recently, we developed the Buffalo concussion bike test that we validated against the treadmill because sometimes people can't go on a treadmill, but they can go on a bike. And it's also a better way to collect data if you're doing physiological studies of concussion. The important part is how you conduct the test and when you stop it. So these are the stopping criteria, it says during the treadmill test, but it also counts for the bike. And basically, we have them rate their overall condition before they begin exercise. And then once their condition changes by 3 or more points from the baseline value, we stop the test. And that can be an increase in their headache, or if they're dizzy to begin with, by 3 or more points combined, or a new symptom appears and we give a point for that. But once, say, someone goes from a 3 before the test and now they're at stage 7 or 8 and they're saying that their combination of symptoms is a 6, we stop the test. That was just based upon sort of some theory and empiric observation, but it seems to work. Now, if someone's very symptomatic at rest, they're reporting a baseline level of symptoms on this FACES scale of 7 or 8 or above, we don't do the test. We will wait a day or two until symptoms stabilize and they calm down. We don't want to make someone very symptomatic with the test. A little bit of symptom exacerbation is okay, but too much is not. This will just give you an idea of what someone looks like who's attaining symptom exacerbation. He's walking on a treadmill, and you can't hear his voice, but you can see it in his face that he's starting to complain of increasing headache and dizziness, and he basically stops very shortly after this. And you'll notice this was a good athlete. He was a Division I soccer player. He's only walking on that treadmill before he's stopping because of his symptoms. So he's clearly not back to full exercise tolerance, and we had to give him an exercise prescription to help him recover. So we use exercise as medicine to treat sport-related concussion now. This is how we do it. After we establish the diagnosis on the treadmill or the bike because of their symptom threshold, we then give them a sub-threshold exercise prescription. We take 90% of that heart rate they got to on the treadmill or the bike. That becomes their target heart rate to work at. Now, it's important that they have a heart rate monitor because this is literally like a dose of medication, and they have to know the heart rate. We give them an actual heart rate range to work in. And if they don't achieve that heart rate, they may underdose and not get an effect. But if they go too far above it, then they're going to overdose and get a side effect. So we treat this like a medication. We tried to get them to do it 20 minutes a day minimum at the target heart rate. They can warm up to it and cool down afterward, but 20 minutes per day minimum, or we just tell them stop at symptom exacerbation. And we say for home purposes, a 2-point increase in your symptoms at any point compared to baseline, you probably should consider stopping. And if you want to go for 40 minutes, that's fine. But if you have to stop at 10 minutes, that's what you do. Most people tolerate a stationary bike first a little better because of the vestibular symptoms many people have. But once they're tolerating that and feeling better, they can run. We try to get them to do it every day of the week. And then we increase the target heart rate depending on how they're doing, what kind of athlete they are, every few days or every 1 to 2 weeks, or you can retest on the treadmill or bike to establish a new threshold, but that can only be done really in training rooms and PT offices. Once the patient is exercising at 80% or more of their age predicted maximum heart rate for 20 minutes or more without symptom exacerbation several days in a row, then we declare them cardiovascularly and cerebrovascularly recovered. Now, why even do this? Well, the idea is to identify each athlete's individual threshold and give them a specific heart rate to work at so we can treat hopefully both acute concussion and those with persistent post-concussive symptoms. And the best way to improve this control that we seem to have lost after concussion of autonomic nervous system function is through aerobic exercise training. It's really better than any drug in that it can affect the entire autonomic nervous system, not just a part of it. The first paper we published was in 2010. This was a small non-randomized trial of athletes and non-athletes. And we were just interested in would this improve their symptoms over time. And when we looked at the non-athletes on the left here versus the athletes on the right, it turns out that if you were a non-athlete, you did get better. I mean, you had a lot of variation in your symptoms, but they all got back to work. But if you were an athlete doing this, you got better a lot faster, about 3 times faster than the sedentary people. So this approach does work in non-athletes, but it doesn't work as well. Now, Dr. Kurowski in Cincinnati a few years later did a much better study where he actually randomized kids with concussion from the emergency room who had persistent symptoms beyond a month to either aerobic exercise or a placebo stretching group, subthreshold exercise versus stretching. And what you see here is after a run-in period of about a week or so, the aerobic exercise group recovers faster than the stretching group. And he interpreted this to say that it looks like active rehabilitation is potentially beneficial, and it looks like you get a physiological effect beyond that of an attention placebo effect that you would have got with the stretching group. Now, again, these are in patients who are persistently symptomatic beyond a month. More recently, we've taken this premise and applied it earlier on after concussion. So in a sense, not waiting until patients have been symptomatic for weeks or months, but trying to intervene early and see if we can improve on their recovery and perhaps prevent some of them from going on to delayed recovery. So this was a randomized clinical trial where we had high school athletes seen within 5 days of their concussion, randomly assigned to aerobic exercise like I talked about, or a stretching placebo group. And you can see that about half of the subjects in each group were female, which was great because there are fewer female studies than on males in concussion research. And you can see that they were seen within an average of 5 days of their injury. So they are still symptomatic. If you look at the row below that, you see their PCSS, post-concussion symptom scale score, and they're both above 30, indicating that these patients are still pretty symptomatic at the time we're evaluating them and using this exercise prescription. This is just what's called a consort flow diagram that shows you how many people got assessed and were eligible and randomized into the study. And in the end, we had 52 randomized to aerobic exercise and 51 to placebo stretching. These are the recovery data. This is a survival analysis. So think of that, those lines representing how many people remain symptomatic over time. And you can see after about a week, much like in the other study, the aerobic exercise group in blue starts to separate and recovers faster over a month than the group that was randomized to stretching. We kept track of their symptoms every week, and they came in every day, and they came in every week to have a new treadmill test, and each group got a new exercise prescription, whether that was aerobic or stretching. How much faster did they recover? Well, the median difference was 4 days. That is, if you were in the stretching group, you took 17 days versus 13 days in the aerobic exercise group. This was significant. When we looked at those who went on to have a long recovery, which is defined as more than a month, only 2 in the aerobic exercise versus 7 in the stretching group took longer than a month, but this was not statistically significant because it was rather uncommon. So we didn't prove that early intervention actually prevented delayed recovery, which was a little disappointing. But what was gratifying was that the females responded as well as the males when given exercise. There are several studies that show females have more symptoms after concussion than males, and they may take longer to recover. But it looks like if you treat them both with subthreshold exercise, they do equally well. So just going back to this, the best study on the natural history of concussion in adolescents was done in Canada by Dr. Zemek's group up in Ottawa, and it's called the 5P study. And the paper, first authored by his colleague, Dr. Gruel, if you just follow up adolescents a month after injury and ask them if they're still symptomatic, about a third of them will qualify for being persistently symptomatic at 1 month. So that's a significant amount of children. I just showed you that in our placebo group, we had 15% who were persistently symptomatic, and in the aerobic exercise group, it was 5%. But it wasn't statistically different. I'll come back to that in a minute. Now, I know that not everybody has access to treadmill tests and this sort of approach, but it doesn't mean that primary care doctors or other types of practitioners can't utilize this approach without treadmill testing. So this paper published last year looked at how we do this with exertional testing and a heart rate monitor that the child goes home with, how we do this with exertion testing, but the athlete doesn't have a heart rate monitor, and how we do this without even doing exertion testing. So how we do this, sort of the philosophy of it. And what we do is we provide the patient with a chart, and we have them start out at a 50% level of their maximum heart rate in terms of doing their exercise with their heart rate monitor. And we have them try to do that for 20 minutes, and then they progress and increase 5 to 10% every day, depending on how they do in terms of their symptom exacerbation during exercise. So if they have a 0 or just a 1-point increase during that stage, they can go on to the next stage and to a higher heart rate. If their symptoms go up by 2 during that particular stage, they're supposed to stay there for another day and then try to progress. But if the symptoms go up by 3 or more, then that's too much and they have to go back to the prior stage. And so using this form and this FACES scale down here, you can, have them do this do the strategy without necessarily having them do a formal treadmill test. Now, I showed you before that the early subthreshold exercise helped people recover faster, but didn't necessarily reduce the incidence of delayed recovery beyond a month. This is latest data from a replication study we did with more centers on the same type of study where people got randomized to subthreshold aerobic exercise or placebo stretching. We had more subjects and more injured subjects. And anyway, we found very similar results in terms of those who got aerobic exercise were more likely to recover within 4 weeks versus stretching. So you see after about a week, the aerobic exercise group starts to separate it out and recovers faster than the stretching. But in this study, gratifyingly, we saw that there was a significant reduction in the incidence of those who went on to delayed recovery. So this is the first time that we showed that early intervention actually significantly reduced the rate of symptom persistence beyond a month. How soon can you do this? So I have a table here of the previous, what's called RCT, the initial study I showed you. And the data I just showed you in the prior slide was from our American Medical Society for Sports Medicine RCT that replicated the first. And basically, this was done in those who had been seen within about 5 days in the first study and 6 days in the second. And the range where they were getting this type of evaluation was 1 to 10 or 2 to 10. So basically, if you follow the stopping criteria on the treadmill test, you can do this as soon as 2 days after injury, or certainly within the first week. And it's safe to do it as long as you follow the stopping criteria, and you can give them an exercise prescription in the first few days after injury. The other way we use exercise tolerance testing is in diagnosis and prognosis. So what do I mean by that? Everybody is looking for a way to make the concussion diagnosis more objective. Going just by symptom reports is problematic because the symptoms are nonspecific and can be seen with a variety of issues, especially in young people. So, everybody's studying blood biomarkers, saliva biomarkers, imaging biomarkers to try to make the diagnosis more objectively based. But I would argue that if you have the ability to assess exercise tolerance, this may be just as good. So we think it's a physiological sign of acute concussion. In this, we did a recent randomized trial of giving the treadmill test within the first week after concussion or not. And in all 27 adolescents that were diagnosed with concussion by the physician, they were significantly exercise intolerant on the treadmill test. That means they only got to about between 50 and 70% of their predicted maximum heart rate before they stopped because of their symptoms going up. So you really don't need an fMRI or a DTI or a blood test or a CAT scan to diagnose concussion. You need a good history and physical examination. And if you're not sure, you can have a trainer or therapist or an exercise physiologist assess their response to exercise. And if they stop exercise early because of symptom exacerbation, we think that's a pretty good sign, objective sign that they are concussed. And we think that exercise intolerance is a proxy for this abnormal concussive physiology that I've discussed. It's altered autonomic control of cerebral blood flow. And there may be some effective concussion even on cardiac function to limit oxygen consumption and delivery to the muscles. Probably not as important as the first, but consideration. What about prognosis? So again, we're doing this exercise tolerance testing early on to sometimes diagnose concussion, prescribe treatment, but also get an idea of how concussed they are. So in the same study, the degree of early exercise intolerance was the strongest predictor of who would take longer to recover. That is, the lower your heart rate when you stopped exercise because your symptoms went up, the longer you took to recover. And if you combine this with a brief physical examination of these various systems, we had pretty good ability to predict who would recover within 2 weeks or who would not. This just shows the amount of variance explained by recovery by different tests. The first part of the pie there, the blue, is the exercise tolerance level. The next there is dizziness during a physical exam test called the vestibular ocular reflex, some other physical exam findings. But the most of the variance in recovery was explained by exercise tolerance level. And if we look at those who stopped at a low threshold, here the dividing line was 135 beats per minute versus those who got to more than 135 before they stopped. You can see you were much more likely to have a prolonged recovery, which we defined as more than 21 days, if you had a low heart rate threshold than if you had a higher one. You were much more likely to have a normal recovery. What was the difference in recovery? 2 weeks versus 2 months. So that's a pretty big difference, indicating that if you're very exercise intolerant early on, your prognosis for recovery is not so good. Now, remember, this is untreated. This is not if you're treated with exercise. And every beat in minute increase in heart rate threshold, that is, the more exercise tolerant you were, you had about a 0.8 days shorter recovery. What level of exercise is too much, even if it doesn't exacerbate symptoms? We really don't know that. The best answer now is anything that does not exceed the individual symptom exacerbation threshold appears to be safe. So we tell patients if your symptoms go up by a count of 2 or more, stop. If not, you can continue as long as you want to until you get tired. And I thank my colleagues at Children's Hospital of Philadelphia for promoting that approach. Now, this is not the return to sports strategy. I want to be clear about this. Just because somebody can exercise on the treadmill or the bike and not have symptoms doesn't mean they go back into sport right away, or doesn't mean they've completed the graduated return to sport protocol. This is just using individualized exercise within the first days after injury while the patient is symptomatic. These are not asymptomatic people, to safely speed recovery, and we think prevent some athletes from developing prolonged post-concussive symptoms. So we're starting to build an evidence base of a benefit or no harm of at least moderate levels of physical activity or prescribed controlled exercise for both acute concussion and those with delayed recovery. The initial studies that looked at retrospective recall of moderate physical activity were mostly, again, not randomized trials, not prospective, but except for the Thomas study, which looked at different amounts of rest. But at least they suggested that moderate levels of activity weren't harmful. And we're building up a bigger evidence base that if you actually prescribe some form of controlled aerobic exercise, you can help those patients with delayed recovery. And it looks like speed recovery acutely from concussion and prevent some of these patients from going on to delayed recovery. Now, there are other groups that have looked at this. The Pittsburgh group looked at a secondary analysis of one of their trials where they sort of separated out rest versus more controlled activity depending upon your initial presentation after concussion. This was the study where they randomly assigned ED concussed patients to 5 days of strict rest versus usual care, which was 2 days of rest followed by increasing activity. They had a symptoms group who had more symptoms than signs. In the signs group, they had either loss of consciousness more than 30 seconds, confusion, or post-traumatic amnesia. And they found that the symptoms group who got rest didn't do very well with that. But the signs group had a better response to stricter rest prescription than the symptoms group. So there may be some, again, difference in what you will recommend depending on if someone's quite confused or has amnesia versus they don't. So concussion is heterogeneous. Treatment recommendations should be individualized. That's absolutely true. Rest should be individualized for those with concussion seen in the ER, depending on whether they're predominantly exhibiting symptoms versus these signs as they define them. So the old view in terms of activity after concussion was, I like to use the analogy of a torn ACL. In the 1970s and 80s, this is how ACL tears were treated. There was no arthroscopic surgery. They put them in a cast for 8 weeks and then took the cast off and had to deal with all the iatrogenic atrophy and stiffness of the joint. And I think in the past, we were putting our brains to rest after concussion for far too long. We advise patients to rest until all their symptoms go away. Don't do anything until all your symptoms are gone. Well, most teenagers are not walking around life symptom-free. Everyone's got life symptoms. The question is, are your concussion symptoms gone? And what does rest mean? Well, if rest means, not doing any physical activity and kind of staying in your room and not interacting with your friends or teammates, you can see where an athlete would start to become psychologically impaired by that. And I think we were actually increasing their symptom load by doing this in some patients. It worked with the ones who were going to recover fast anyway, but not with the ones who are going to take weeks or months to recover. So the last International Concussion and Sport Group met in Berlin in 2016. We were supposed to meet in Paris last year, but it's not going to be till next year now because of COVID-19. But the new view is that instead of strict rest in a dark room, we employ relative rest for a few days. That is, again, kind of get back into daily life a little bit, but don't exceed your symptom thresholds. It may need to be radical rest for kids in school. Most kids need a day or two off school after concussion, just so they don't make things worse. But after that, we try to keep them in school as much as possible. Once their symptoms stabilize, we talk a lot about getting back into activity gradually and identifying and stay below their cognitive and physical symptom thresholds. So if something makes you symptomatic, stop, take a break, and go back and do it, but for a little less time than it took before, and build up gradually. And there are emerging active treatments for the physiological disturbances we see in sport-related concussion and in those with PPCS. We think that subthreshold exercise is treating this autonomic dysfunction I mentioned to you, but we haven't proven that yet. There may be several ways it works, but there are treatments now for the oculomotor, vestibular, cervical, psychological, and cognitive behavioral symptoms and signs that emerge after concussion that are beyond the scope of this talk today. So another one of my lame jokes, that's supposed to mean my handwriting after medical school. Actually, that's better than my handwriting after medical school. But basically, what I want to leave you with is don't cocoon these patients. Even for those who are acutely concussed within that first week and they're symptomatic, you can get them active. And I'm not saying you have to do a Buffalo concussion treadmill test on anyone, but they shouldn't be resting in a dark room more than a day or two. Get them active in a controlled way. That's it. That's the talk. That's Dr. Willer to my right. And we've been working together for 20 years in an international collaboration between Buffalo and Fort Erie, Canada. And without Dr. Willer, none of this would have been possible. So I want to thank you for your attention. And if there are any questions, I'll try to answer them.
Hey, John. So first of all, I'd like to thank you for, first of all, for speaking today. And thank you for giving such an incredibly educational and informative talk. Exercise truly is medicine. As you know, we've discussed this before. It's one of the main things that I use to heal myself and my brain injury. Just a brief word about Brain Changes Initiative. First of all, for the audience, my name is Dr. Matthew Galati. I'm the founder of Brain Changes Initiative. Brain Changes was founded back in 2019. It was inspired by my own recovery from a traumatic brain injury. And what our mission is to fund groundbreaking research around traumatic brain injury and to provide education, awareness, and support for brain injury patients, their families, medical professionals, and people who just want to live a brain healthy lifestyle. So on that note, John, there are a few questions. I'm going to pick a few to highlight here. So 1 second. So there's a question here. Is the bicycle test as accurate as the Buffalo treadmill test? Is there a bicycle test?
Yes, the Buffalo concussion bike test, we have a couple of publications on it now, is just as accurate in identifying the symptom threshold as the treadmill is, and it raises the heart rate at the same rate that the treadmill does. The bike is a little different. It's got 2-minute stages instead of 1, but that's because of the nature of the bike. You have to do that. And we matched it on metabolic equivalence to be equal to the treadmill in terms of, again, raising the heart rate and identifying that symptom exacerbation point the same as on the treadmill test. So you can use them interchangeably that way. It was important that they be metabolically equivalent.
Okay, and here's another question. Would you recommend patients do the exercise test on their own, or must they do it with a medical professional?
Well, ideally you do it with supervision of an athletic therapist, a physical therapist, an exercise physiologist, a physician. I have had patients over the years who have looked the stuff up online and done their own at home, which is pretty clever, I think. And, you know, they seem to be able to do it. And as long as they're not pushing their symptoms too high, I think it's fine. So there are some people who could do it on their own, especially a trained athlete, I think, could get on a bike or a treadmill. But, you know, for most people, we recommend that they do it under supervision, because we don't want to, you know, harm anybody, and we don't want anyone falling off a treadmill, that kind of thing. And, you know, if your symptoms go up pretty precipitously, you might need a little help getting off that treadmill. So, you know, a professional or a college athlete, I think, could do this easily enough. But for most, we recommend supervision.
Okay, and there were a few people in the chat that were asking for some clarification around maybe if you could go into further explaining a count of 2 to clients in their symptom change.
Yeah, so again, that's the subjective part of this, but what we just asked them is, how are you feeling today? And again, on this 0 to 10 scale, 0, no symptoms, 10, I feel awful. Again, most people with a concussion in that first couple of weeks are going to say, well, I feel like I'm a 3 or a 4 or a 5. Again, very subjective. But you use that, and then at every minute during the treadmill, we ask them, okay, how are you feeling now compared to where you started? And if they go up, say their headache goes, now they're 8 minutes into the test, their headache goes from a 3 to a 5. Well, that's a change of 2. Now at home, we would tell them, if your headache goes up by 2 or your dizziness gets worse by 2, you should stop there because you're at home by yourself. When we're doing the treadmill test with supervision, we let them go further to a change in 3. So say in the next couple of minutes, now they get dizzy. Now there's a change in 2 from headache, 1 from dizziness, that's 3. We stop the test.
Thank you. And actually, there's another question here, and I'm curious about this as well. If exercise is not implemented right away and the concussion goes untreated, can exercise still help with symptoms, or is there a window of time?
Yeah, the answer is yes, it can. But it's clear to me that the earlier you get at something, like anything else in medicine, the easier it is to treat. So if we're, I think our randomized trials have proven that if you do this early on, you will get the fastest response. Now, it doesn't mean that if someone's symptomatic for a month or 2 or 6, that this will not help as well. I just don't think it will help as rapidly. And that's been my experience. If we get people who are months out, we definitely use exercise. Very often though, Matt, they have other conditions that are causing symptom persistence, oculomotor problems, vestibular problems, cervical problems that haven't been treated. So they're getting multiple modalities of treatment at that point, including aerobic exercise. There are a couple of people where it seems to be exercise intolerance is their only problem, and they're a month or 2 out. So it works. It just takes a little longer because you're treating something that's been there for a month or 2.
I agree completely. And then last question. So this is a question from the audience. I have a client experiencing trigeminal nerve pain response to stress. He is very physically active. Could this be contributing to his facial pain?
The physical activity?
Yep.
Not sure I'm qualified to answer that. If it depends on how stressful the physical activity is, I guess. If his physical activity is reducing his anxiety and stress, then it should be helping. If if he's doing something really intense and challenging, and his cortisol levels are going up, that might be aggravating things. So I think it depends on what he's doing. But I frankly have never treated a patient like that, so I'm just guessing here.
Gotcha. Okay, thanks, John. And again, I'd like to thank you, and I'd like to thank OBIA. We're honored to be partnering with OBIA on such an incredible speaker series. And I would like to thank our 2 sponsors, Helios and NeuroChangers, and I'll now hand it off to Matt Sanchez from NeuroChangers to say a few words.
Thanks, Matt, and thank you, Dr. Leddy, again for an enlightening talk. For those of you listening that have not ever used that Buffalo treadmill test, we've been using it for a few years here at NeuroChangers, our physio clinic, and the subthreshold exercise protocol that he described, I can attest to it. It'll change your practice and it'll help you get better results with your clients. It was a game changer for us. We're also very proud to be a sponsor in this OBIA speaker series and to be working alongside Pons and Brain Changes to promote such important topics. At NeuroChangers, we pride ourselves in offering state-of-the-art neuro rehab, promoting both physical and cognitive health and wellness, and working on a new package right now called Wellness Checkpoint. So for everyone listening, if you head over to neurochangers.ca, click on the Distinguished Speaker Series banner just underneath the title there, follow the prompts, you get a free demo of our Wellness Checkpoint. It'll help people post neurotrauma, help manage a healthy lifestyle. And so if you have clients or if you as an individual have had neurotrauma, this will be a really big impact on you. Thanks again, Dr. Leddy. It was a great talk, and I think everyone hopefully will now start using exercise more in their post-concussion rehab.
Thank you again, Dr. Leddy. That was an incredible presentation, and we really appreciate the time that you took to come and share your knowledge and your experience with us. A special thanks again to our sponsors, Pons and Neurochangers, for making this possible. I also want to invite you to watch some of our other webinars where we have incredible speakers, and I know that you will learn a lot of wonderful information. Thank you again.